In this video, we present the unique case of the treatment of a iatrogenic lateral meniscal root tear following ACL reconstruction. Our patient is a 32-year-old male soccer player who underwent ACL reconstruction with hamstring autograft 15 months prior, as well as a partial medial meniscectomy on the same knee approximately 7 months prior. He represented to us with significant lateral-sided pain, which never subsided following his ACL reconstruction. Physical examination of this patient consisted of sharp, stabbing, constant pain on the lateral aspect of the knee. The patient had motion from 0 to 110 degrees with a mild effusion, as well as lateral joint line tenderness. Imaging was obtained. There is no evidence of significant tunnel widening. However, with respect to the graft tunnels, the tibial tunnel does appear to be quite posterior in nature with regards to its aperture within the joint on the tibial plateau. MRI evaluation demonstrates likely intact ACL, status post ACL reconstruction, with lateral meniscal root tear directly adjacent to the ACL graft. This is more clearly demonstrated on the still images shown here by the arrow demonstrating the lateral root tear on coronal and sagittal imaging. CT scan shows similar posterior position of the tibial tunnel with no significant tibial tunnel widening. This anatomic image shows the relationship between the ACL footprint and the posterior root of the lateral meniscus. One can see how if they are posterior with their ACL tunnel, it could potentially violate the posterior root of the lateral meniscus, as seen here. The surgical indications for meniscal root repair are an acute traumatic tear with normal or near normal cartilage, minimal radiographic evidence of osteoarthritis, or a chronic symptomatic tear in a non-arthritic patient with the ability to comply with postoperative rehab protocol. Our patient fits into this third category. Here we demonstrate the intraoperative procedure for this patient. Following diagnostic arthroscopy, the posterior root of the lateral meniscus was identified as torn. The probe identifies the proximity of the ACL graft to the lateral horn root attachment, and it was noted that the tibial tunnel likely violated the root, causing this iatrogenic tear of the root at the time of the index surgical procedure. A curette was then used to prepare the footprint for the meniscal root. An incision was made on the anterior medial tibia for bone tunnel entrance for transtibial pull-out tunnels, and using an aiming device, the first hole was placed into the meniscal footprint using a 2.4 mm drill. A second tunnel is then placed approximately 5 mm anterior to the first tunnel using an offset guide. The tunnels were visualized arthroscopically as you see here. An arthroscopic cannula was then placed in the medial portal. An arthroscopic suture passer was then used to place 2 sutures into the posterior lateral meniscal root. A nitinol suture passer is then passed through the tibial drill tunnel and used to retrieve the sutures individually. A grasper is used to retrieve both the nitinol suture wire and the suture passing through the meniscus, and the sutures are sequentially passed through the tibial bone tunnels. When passing the suture, it is important to note that we pass the posterior-most suture through the posterior-most tunnel to avoid any tangling of the sutures during passing through the tibial tunnels. The anterior-most suture is then passed through the anterior tunnel in a similar fashion. As the sutures are pulled into their respective bone tunnels, the reduction of the meniscal root can be appreciated, with care taken not to over-reduce the meniscal root. The cannulas in the tibial bone are then malleted out as the suture is withdrawn from the tibia. Retractors are then placed through the open incision on the tibia, and the tibial cortex is visualized while the 2 sutures are tied over a button on the tibial cortex. Final inspection within the joint reveals well-reduced posterior horn lateral meniscus with 2 alternating colored sutures dunking into the respective tibial tunnels. Postoperative imaging demonstrates no change from prior with the exception of the tibial button on the tibial cortex. Postoperatively, the patient was kept non-weight-bearing until 6 weeks post-op, prescribed pain medication as needed, with an estimated return to sport at 6 months. Upon review of the literature, repair of meniscal roots do have relatively high success rates. One review of 13 studies with a mean follow-up of 33 months found that 62% completely healed with improved patient-reported outcomes. There's an approximate 5% failure rate overall within the study group. An additional study, including 56 patients with a mean follow-up of 3.4 years, in which the patients underwent second look arthroscopy, revealed 70% stable and healed menisci after meniscal root repair, once again with higher subjective knee outcomes and less progression of medial joint space narrowing. A study by Laprade et al. Of 45 patients undergoing the aforementioned technique with minimum 2-year follow-up found improvement of Lisham and Womack scores in patients both aged less than and greater than 50, with similar outcome scores in both groups, demonstrating that this is an effective and reproducible surgical technique. While rare, this phenomenon has been previously described in the literature for other types of meniscal root tears. Here, Laprade et al. Described a 2-patient case series of anterior horn medial meniscal root avulsions due to malposition of the tibial tunnel, as well as the subsequent treatment of this condition. Laprade et al. Also described a similar presentation, such as ours, in which they treated a patient who came from an outside hospital who experienced posterior lateral meniscal root tear following anterior cruciate ligament reconstruction due to posteriorly placed tibial tunnel at the time of the index procedure. This patient differed from ours in that they underwent a double bundle reconstruction technique, and also when they presented, they had retore their previously placed anterior cruciate ligament graft, necessitating both revision ACL reconstruction as well as meniscal root repair at the time of surgery. Thank you very much for watching our video on the treatment of an iatrogenically caused lateral meniscal root tear.